Arif, yeah.
Sorry for the inconvenience. Screen? Okay. So RC, okay, I will start from that was stuck. So RC was done without any complication. It was the next go for the L6. Yeah. So here we took a wiring first and a 2.5 balloon for standing dilatation for the lesion preparation. And ultimately we proceed and we feel difficulties to stand the vessel, L6 tortuous vessel, and it is also calcified. Then what we did, we took another wire. We took two wire for the LCX, and over the wire, then again we predilate the lesion. So we think the predilation was sufficient, and then again we try to introduce the stent. So, but suddenly we, after two push, we observed the stent was dislodged in the wire. The stent dislodged from the balloon and it was hanging in the wire. So it is seeing that partially distorted. So it's a very crucial moment. So we took what we did. We took another wire so that we can trap it and pull it in the catheter. And ultimately we could it possible. And after trapping it, we pull it towards the radial sheath. So we can see how we trap the wire. We took one wire inside the stent and another outside the stent. Ultimately, we trap it and then pull it to the rail sheath. But the problem is that the stent was distorted in such a way that it was not inserted into the sheath, and ultimately we failed to trap it inside. So we have to change our strategy. What we did, we took another puncture from the right femoral artery, and it's not. Okay.
Now we got. We have the slides now. Yeah.
Okay.
Okay.
So what we did a femoral access, and through that access, we introduced the catheter and a wire up to the right radial artery. See, here is the another wire and with sheath. But in this situation, what we did, we again trapped the stent and to pull it from the right femoral axis and pull it towards the right femoral axis. See, we are pulling it across the right femoral axis. But here we have took a bigger sheath. Even the bigger sheath, it was not inserted in the bigger sheath because the shape was such a way distorted. So we are in a very puzzling situation because we use right radial axis, we use right femoral axis, even that we failed. Then what we did, we put another right femoral axis so that we can some push to introduce in the right femoral sheath. See, we are pushing the stent to introduce in the sheath. Even then we failed. Last of all, what we did, we made this snare that was shown by our Ashok sir, the handmade snare. It's a very easy and handy techniques. And initially, we made this in such a way in the outside and introduced it in the right femoral axis. At first attempt, we failed to trap the stent to this handmade snare, but our next stent approach, we could pull it and we through the sheath, we could keep it externalized in the right femoral axis. So this is the appearance after the bringing the stent with the handmade snare. So the stent was totally smashed and turned into a point. See, this is the stent that was trapped in the handmade snare. Totally distorted. And then again check that whether there was any damage in the femoral artery, as it was a very tortuous and distorted stent. So, coronary stent dislodgement during PCI is a very rare but serious complication. The incidence is not that much days, it is 1.4 to 3.4%. Different retrieval techniques or unexpanded stents have been implemented with a success rate about 86%. So control over the dislodged segment is the most important thing to get the success. and multiple access manipulation is crucial. So handmade snare is very comfortable to use. It is very cost effective and attractive option to removal of this dislodged stand. Thank you.
Thank you, Dr. Arif, for your brilliant case and nice demonstration, as well as innovative procedure, meaning that the making of snare by handmade. And so we must have to congratulate you. But did you take any radial angiogram after the procedure, whether the radial artery is patent, whether the radial artery is all right or not? Though radial artery is lost, no problem. In 95% cases, it is persist. 3 to 4% cases in radial approach will lose the radial artery, no problem. But you should check what is the situation of the radial artery after
Exactly,
this
sir.
lengthy procedure.
As we did very less maneuver in the right radial artery, that we did not take any shot,
right.
but we should take it. It should be done. Thank you, sir.
Thank you once again.
Right femur, sir, 8, sir. 8 friends.
Can I make a comment here, please?
Right, sir.
Could I make a comment here, please? Yes.
Yes, sir.
Now, once you decide to relinquish the stent, that you're not going to put it back in coronaries, one other potential option you could do, which would be a simpler technique, is you cut the hub side of the guide catheter and the wire, and you stabilize the catheter, you take the sheath out and put a bigger size sheath in the radial artery, and then try to internalize the mangled stent into that sheath and pull out in together, all together. That's one. Secondly, I wanted to point out, when you pull the stent back after you've wire wrapped the stent and you're pulling it back, there is potential for injuring the endothelium of the vessel as you drag it back out. It is always a good idea to put a smaller balloon at the proximal end of the stent and do a low pressure inflation and drag the balloon back with the stent along with it. That would prevent the injury to the endothelium along as it gets pulled back. So those are the two I wanted to highlight.
So we use here the 1.25 balloon, but it introduced only the partial portion of the stand. That was the problem. That was frequently it was dislodged.
So you partially
Yeah.
deploy it, so the balloon remains proximal to the stent.
Yeah.
So when you pull back, basically you are protecting the vessels with the balloon.
Exactly, sir. As the distal portion was distorted, that's why we could not introduce the balloon to the end. So partially it was inserted, sir.
Sorry, how did you bring stents from brachial artery to femoral artery? How did you
Sir, what we
bring
did,
it? Bring it.
we inserted the catheter through the right radial artery up to the right femoral artery up to the right radial artery. Then we took another wire, PTCA wire, and just we reinserted the stent with the next new wire. And we took a 1.25 balloon, and the half portion of the stent was inserted with the 2.5 balloon. Then when it was partially inflated, then it was strapped in the balloon and the wire, and we smoothly just track it towards the right femoral artery, sir.
Very good trick.
Thank you, sir.
Thank you very much. Excellent cases.
Thank you, sir. Thank you.
And at this point of time, I think we have seen fantastic cases from all the presenters today. Very interesting how to bail yourselves out of complications and complex PCI with the usual Judkins. So we probably have to have open mind that it does work as well. So, and we are on time. We are probably just 5 minutes behind schedule, which is all right, So thank you very much for the audience who have stayed. There is a cultural program next coming up and a dinner. We appreciate your patience for staying with us the whole day. Thank you.